registrants will receive a copy of this presentation following this webinar. Next, all registrants will receive a copy of this presentation and a recording link to the webinar following this presentation. The information will be sent to the email in which you registered for this webinar. Before we get into today's agenda, I would like to introduce today's presenters. First, Jason Peely joined MediAnalytics in 2013 with a background in product management, software engineering, and direct patient care. He brings more than 24 years of healthcare experience into his role at MediAnalytics. Prior to joining Medi, Jason worked for several software companies where he developed mobile, portal, and SaaS products targeted at healthcare clients. Jason also spent 5 years as a software engineer. Prior to breaking into software, Jason spent 10 years in direct patient care as a registered respiratory therapist at Sharp Memorial Hospital before getting his degree in software engineering. Next, Melissa Linder joined MediAnalytics in July 2018 with a background in quality management and direct patient care. She brings more than 20 years experience in healthcare quality, specifically working with providers and payers to achieve and maintain healthcare quality goals. Melissa has spent the bulk of her career in healthcare quality management, most recently as Director of Quality and Care Management with a large multi-specialty provider group where she developed the Quality and Analytics Department. Melissa spent several years in the payer space working with Medicare and Medicaid products, HEDIS, and STARS, accreditation, and population health. Prior to joining the healthcare quality field, Melissa spent 8 years in direct patient care as a certified medical assistant working in the primary care setting. Melissa earned her master's in healthcare administration from Des Moines University. And finally, we have Samantha Ferretti, who joined the NCQA team 9 years ago in the data collection and audit department. With an interest in identifying customer needs and developing products, Samantha transitioned to NCQA's Information Products team in 2013, where she has focused on developing the data NCQA collects into viable products for their many stakeholders. Samantha received her degree in healthcare administration and began her career in hospital systems. So thank you so much for joining us today. And with that, Jason Peely, AVP of Product Marketing, will start today's presentation.
Thanks, Jessica. So today we're going to be talking about the realm of value-based performance management with particularly a focus on quality. We're also going to be talking about some of NCQA's benchmark capabilities that we're pulling into our products and the benefits for you there. And then we'll also end the session with a little Q&A. So today I want to talk mainly about quality, what it is, how it's viewed by different stakeholders, the challenges around it, and some of the items to focus on in the near future based on direction that quality organizations are going. As everybody knows, there's so many different measures and measure sets out there. So the big challenge is, where do you start? What do you focus on? Data is a huge factor, and more accessibility and accuracy is a challenge as we run into data sources that aren't necessarily standardized. So how do you know what to focus on, and how do you know what resources and tools are best for you and what's going to help you in this quality journey? So one of the big challenges in quality is misalignment, misalignment between the providers and the health plans. Although everybody agrees that quality measures are too complex, there are and which the quality organizations are trying to respond to with changes to simplify those measures. But still, as we can see, health plan executives and physicians don't necessarily agree 100% on the fact that quality measures can improve care quality. So one of the first things to really understand is the different stakeholders' priorities in measuring quality. If you understand the priorities and the problems that these stakeholders are trying to solve, it's going to help you come up with a much more effective solution for those stakeholders. So for patients, the first stakeholder, they really need information that's going to help them make their healthcare decisions, and they want measures that are specific to their conditions. One of the issues today around publicly reported quality information is that it's not always pertinent to patients and the problems that they're having. So increasing that patient-centric view in quality is super important to our patients in order to get them to engage and understand what quality is all about and how it applies to them. For clinicians, they're accountable for the measured results. So they really use measures as a guide for improving their clinical results, improving care, but many of them are concerned about the lack of high-quality outcome measures. A lot of times we've got specialties where there's not a lot of coverage in quality measures, so there are things that are not necessarily specific to them. And the problem is there are so many different measure sets out there and so many different things they're trying to accomplish that they really are beginning to suffer under this burden of measure burnouts. Health systems are looking to help them target where to improve care within their system, where they might be falling short and where there's room for improvement. But again, just like the clinicians themselves, they're really concerned by the number of measures that they're on the hook for. So if you think of all the different organizations that they're reporting into for quality, there's insurance contracts, there's Medicare, there's different accreditation they have to go to, state regulations. It's huge and it's overwhelming. Some of the measures are outside of their direct control, or they're complicated to do well in because of the nature of them and how they're set up. When I've been to star rating conferences in the past, one of the biggest complaints that everybody had was the fact that for patient satisfaction, which has such a high factor in their scores, it's almost impossible to score well given the rating system that they have today. So if you think of a typical survey where you're having to score something, even if it's something like you're scoring a product or you're scoring a website, to have a range of 1 to 10, if you're going to give something a 9 or a 10, that means it's pretty near perfect. So with star ratings, these guys have to get 9s and 10s in order to get credit for those particular ratings. And so that makes it really challenging because the majority of patients today are just going to look, if they're taking the time to do these surveys, they're going to look and say, yeah, they did great. It's a 7, 8. That's good. But in reality, they aren't getting credit for those particular measures unless they get those perfect scores. So trying to work with the quality organizations in how they're measuring things is really key here. And I do think that most of the quality organizations are starting to change their methodologies and improve and work on simplifying things for everyone. Finally, there's employers. So they're really looking for metrics around purchasing contracts, and they really want to measure what's going to help their employees make informed decisions about their health care, whether it's about things like going for preventative services or if they are exercising, if they're eating healthy, if their BMI is in control. There's a lot of those types of things that the employees are really going to focus in on, and they're going to focus their programs to help their employees with. But the problem is they often lack measures in those areas where there is greatest variation in cost and quality. If you think of a lot of things that I just discussed, things like smoking cessation, BMI, those aren't necessarily things that you're going to get from a standardized input or data. Usually that's things that are going to come from like an employee survey. Where they're self-reporting that they're a smoker or what their BMI is or how much they exercise in a week. And it's really difficult at times when they're not using standardized surveys. So what are you going to do to be able to set yourself up for success once you do understand the issues and problems that your stakeholders have? So a big piece of it on the side of the payers and the health plans is communication with providers. So it really is about transparency between the two different sides. And giving those providers a real active voice in what they're being measured on is really going to foster buy-in from them, and you're going to get a greater sense of engagement from those providers if they're able to help shape what this agreement is and what they're being measured on. There's also considerations around funding to help providers succeed, because health plans have a lot more available to them in terms of personnel, resources, technology. If you think of a lot of smaller clinics and where a lot of the providers are, even if they're in provider groups, they don't necessarily have the funds to come up with some really great, sophisticated data solution, analytics solution. They're just struggling to keep their EMR up to date and get the data in and out of there. They have limited resources and limited personnel. So to help them succeed by helping them with some of these items is really a win-win for both sides. And again, simplifying is huge. So if you think of the types of reports that the providers are getting from the health plans, maybe they're getting them quarterly, maybe not even that frequently. A lot of times, health plans are suffering a little bit from thinking that more is more. So if we do a complete data dump and we give you this huge report on a quarterly basis that tells you everything you might want to know about your performance, we think that's good. But in reality, when you think of the provider's perspective, where they're getting these reports from multiple health plans and multiple sources, and there's all kinds of data in there, and it really needs some sort of interpretation to get to the bottom line, that's a problem. So the concept of simplifying and getting to the bottom line and really letting those providers know how they're performing on the measures they're on the hook for, where there's room for improvement, how they've trended over time is a huge win in terms of getting buy-in from those providers. So you really need to provide that appropriate level of data reporting. One thing that I've experienced when I first got into the analytics field and was working with different hospitals, different health plans around things like this, I suffered from getting super excited about the amount of data that we could provide and the amount of metrics and measures. And so I went in front of a hospital of users where I had care managers and actuarials and benefits people all in there to learn about what we were giving them in terms of a solution for reporting. And I went on my merry way explaining all these great things that we could do. And after about 2 hours, I started noticing that people were not engaging so greatly, or they were getting a very glazed over look. So I stopped and I asked them how they were responding to what we were giving them, and most of them replied that they felt completely overwhelmed. A lot of times you have to remember that the end users of these reports, if they're not specifically an analyst who's trained to interpret data and work with different metrics and dimensions and measures, that these are clinical people and they're not necessarily comfortable with that type of technology. And if you throw a lot at them, it's just going to overwhelm and intimidate them and scare them from engaging in the solution that you're offering them. So what I learned over time was to really bubble up those things that are simpler concepts for people, the low-hanging fruit, things that people can get on board with immediately and start understanding. And once they get past that initial point of understanding the simpler things, then they start being able to get into some of the more complicated and complex things. So I'm really a huge advocate for keeping things simple for end users and letting them determine when they want to go deeper into data and understand a little more complicated stuff. So what can the healthcare systems do in setting themselves up for success? Providers really live in their EMRs, so increasing the interoperability of the EMR itself is huge, and that's a big factor today that's super complicated Because now that everybody is on EMRs and EHRs, there's millions of flavors of those EMRs, and there's really a lack of standardization behind those. So data that you get out of those sometimes isn't so great, or sometimes it's entirely up to you if you have a very custom implementation of an EMR to determine how best to get the data out or get data in there so that the users are looking at a holistic view of the patient with all the different pieces of data in there, giving them the full picture. We are making progress, I'd say, in the industry in terms of that type of interoperability. So when I put it on a personal level and I think of, hey, I go to my primary care provider and he gives me access to a patient portal, and then I might go to urgent care or I might go see a specialist about something, what's becoming increasingly impressive to me is the fact that I'll often get notifications from my primary care provider's office letting me know that there are new results in the patient portal that come from somewhere else completely different. So we are definitely making strides and progress around interoperability, but we still have a long ways to go. The other big thing is utilizing standardized quality measures, like from HEDIS or CMS, as opposed to custom. So we've worked with a lot of different organizations around their quality measures, and a lot of times some of them will come to the table wanting very, very customized measures, or they might want a slightly different wrinkle to a HEDIS measure because it's more accurate for them, which is completely understandable. But at the end of the day, custom measures are very difficult. They're difficult to maintain. They're difficult to expect vendors to be able to flex and have that kind of content in their solutions for you. So where you can stick to standardized measures, you're going to get a little bit more of a win because those standardized measures are widely accepted and they're going to cross over across the different quality measure sets that you might be on the hook for. You also need to ensure that the providers have a voice in this process and are really invested in the success. So where I've heard super great success stories, both from the health plan side and the healthcare side, has been when you get providers and basically charge everyone to understand in the organization down to the people who are drawing the labs and the people who are doing admitting. If they all have a stake in the game for quality and they all understand the importance of it and the impact it has on the daily lives of their patients, you really have a much greater chance of succeeding in these types of programs. So again, in terms of improvement strategies around quality, it really is about quality over quantity. So the other issue that I've seen some organizations suffer from is really trying to boil the ocean with a solution. So when they're going to implement something like a quality solution or some sort of analytics, a lot of times they will come with this huge wish list of hundreds of things they want to accomplish, and what invariably happens is the time it takes to get things into play and the accuracy of that really suffers because there's just so much going on and there's just so much to accomplish. Whereas those organizations who have a really laser focus on the measures that they're going to focus on in the coming year, understanding that they can start simple, they can start by crawling before they expect to run, they have a much greater chance of success. So being able to focus all the resources on small wins initially and getting adoption from your users, it's huge because all of that is going to lend itself to winning ultimately in this game of quality. So you really need to be prepared to adjust your strategy year over year. Once you get things in place and implemented and you've decided on the focus that you're going to have, you're not really done. You're going to do this continuous improvement plan, and that includes changing your focus year over year. So you need to be able to evaluate where you have the most room for growth in your organization in terms of quality, where you have areas of challenge and areas of improvement. And you also need to understand when you have areas where maybe quality measures are tapped out. You've done the best you can in improving a particular quality measure, and so it's not really worth focusing on that area anymore. You want to change your view to those areas constantly that are keeping up with the focus of quality year over year and also addressing the needs of your ever-changing population of patients. So along those lines, you really need to have the perspective of how you've performed historically, how you compare to other organizations. So that's where benchmarking becomes very important. Where do you have room for improvement? And like I said, where you maxed out and need to change your perspective and shift gears. So some of the things that are real-world strategies that work in terms of changing behaviors together as a team, it's really important to set up regular and ongoing face-to-face meetings with key players. So between a health plan and healthcare organization, where historically there may have been some contention or there might be a challenge in working together, if you personalize the relationship and you are meeting face-to-face and including all of the key players in what you're doing, there is a much greater chance of success. So you're coming up with quarterly goals together, you're identifying areas to work together, you're reviewing the data and how you've done historically and where there's room for improvement, and you're really prioritizing those focus areas together. The next one is to be able to align your data needs. So that really does make a win-win situation for both sides. With data, it really has to be about transparency. I've worked with several organizations that were on the hook with multiple ACO contracts or value-based performance contracts. And in the older days, a lot of the health plans would at times treat how they calculate metrics, how they calculate quality measures as their secret sauce, and they didn't want to share it. And so the providers were a bit at a loss because they didn't know how to measure themselves in a way that would reflect how they were going to be measured by the health plan. So at the end of the year, they might find out that they didn't do so great because they didn't understand how they were going to be measured and how that was all calculated. Whereas when they had contracts with health plans that were super transparent, they were able to measure themselves throughout the year and understand what they were on the hook for and improve themselves. And so, of course, they really gravitated towards those health plans which made themselves transparent, because at that point it really was a win-win situation and everybody was really working together. Another important fact is to set up educational sessions. So your users, your healthcare providers and clinicians, and your patients ultimately need to understand things about the cost of services, understanding why it's important to steer your patients away from overuse of the emergency room and get them into their primary care providers or get them to utilize urgent care centers. You also can start sharing costs related to ER utilization, related to diabetes prevention, because if you can get the patients engaged in those kinds of activities, you're ultimately going to be saving yourselves in the long run. And so it's really important that you invest in those tools that are needed for success. And that includes things like analytics solutions, data interoperability. There's a lot of technology out there now that is designed to make life easier in this challenging space. So again, the problem is there's so many measures. So what you really need to be able to evaluate is where do you have completeness of data for a measure. So a lot of times people will go for the bright and shiny measures that are super exciting and cool, that might give them a whole bunch of information and insight into their organization. But you might not have the completeness of data for those particular measures. So rather than trying to create start creating the wheel over again and sources before you can get that quality measure. What's the low-hanging fruit where you already have completeness of data in your organization that you can focus on? Yes, you absolutely need to start working on getting those other data sources in there and those more complicated measures. But again, starting simple is huge, and being able to get some wins under your belt around quality measures is a real game changer. Reliable data is challenging. So we have all kinds of challenges out there. As I talked about with the EMRs, there's not a lot of standards yet. They're starting to develop that as everyone is recognizing that that is a gap in this space. But even when we do have standardized data like administrative data, claims, enrollment, it's still challenging because different adjudicators might have different layouts for the data. You might be missing parts of that data. So that really is a huge challenge. And ultimately, garbage in, garbage out. If you don't have good, clean data and you don't have data orchestration in your organization, then you're going to come to faulty conclusions and poor performance. And a lot of times we see users blaming the solutions, but the solutions can only do so much around poor data or data that might be fractured or misleading. One thing to really consider in your strategy is where do you have measures that overlap in the different measure sets. So HEDIS, MACRA, CMS measures, all of those different pieces, where can you get a win across that spectrum of measures just by dealing with a couple of measures? So that should really help inform your strategy and how you approach this as well. Again, keep it simple. I can't stress that enough. I've mentioned that many times, but it is a huge factor in winning here. And you really need a good data solution, and in-house you really need to be able to do good data orchestration so that you make sure you're doing the best you can and keeping your data as clean as possible. So some of the data sharing strategies, payer and provider alignment is really key. Having a source of truth that both sides trust can be a game changer. So that sharing of data and the simplicity of data is a big part of that. The results to a Health Plan Advisory Council data sharing survey really back this up. So if you look at the first one here, 79% of providers agree that care gap data is untimely. So having that ability to get the data into the provider's hands quicker so that they can respond and make changes and close those gaps in care is huge. Also, being able to optimize the provider incentives. So 56% of providers agreed that the financial incentives aren't large enough. And that's not because they want so much money. It really is about the fact that at times, if you measure the pros and cons, for the providers, it's extremely expensive to bring in some of the tools needed to measure these quality measures, and also the resources. They just lack them. So ultimately, it might be cheaper for them to take the penalty rather than try to set themselves up in a really complicated and challenging way and get those resources. So they have to be able to determine, what's the best path forward for them. So again, setting them up to win is really going to help everybody in the long run. 59% of providers have limited staff members to allocate towards non-clinical things. So they don't have the people to focus on the quality measures and making sure that they're measuring these things successfully and they're able to react to these things. They're just trying to do everything they can to take care of the patients in the way that they need to. So one of the things that we've seen as being a good start, a good base around sharing that data and having a single solution, a single source of truth, is a shared payer-provider solution. And so this sounds like it's really complicated at times, and in reality, it is a little complicated, but what you can do is try to start off with the simplest data sources. So if you think of the spectrum of administrative data, where in the provider's hands it starts off as accounts and charges, and on the health plan side it ends up as claims. If you're able to marry these two sides of the data together into a single source of truth and one solution, you really are getting benefits to both sides. So if you think of, for the provider, they're getting access to a wider breadth of information about their patients, because the huge challenge for the providers today to have a true population health solution is that they don't necessarily have a holistic view of their patients based on the data that they have available to them in the four walls of their organization. So the health plan has access to data about the members that happened outside of that provider's organization. So maybe I was on vacation and I had to go to urgent care, or maybe I had to go see a specialist when I was out of state, whatever. That data doesn't necessarily make its way to the providers, and so they don't have that holistic view of what's really going on with their patients, but the payers can help them with that. For the payer's benefit, the timeliness of data is huge, because if you think of claim lag time as being at least 90 days, that data is already somewhat stale when you're getting it. And so if you think of things like HEDIS season, where that 3 months is going to make a huge difference for you, getting that data from the providers, from accounts and charges, where they can basically turn that data around on a daily basis. That's going to be a huge win for you in terms of understanding what's going on with your members before you get those claims in and those claims get finalized. So that's a big win for the payers to more quickly flex and change their focus for their members. Completeness of data is another big one, especially for the payers, because a lot of times, depending on who you have adjudicating your claims, you might not have the full picture, because a lot of times what we see is what's available on the standardized claim format that is coming from whatever vendor you're using. It might only include space enough for 8 diagnoses or 8 procedures, or even less at times. And so how does that impact you? You're not getting the full picture of the patient, and the quality measures are not going to be 100% correct around that data. The accounts and charges from a provider include all that data, so being able to create that superset and provide it to you is another big win, and it's really lending itself to the patient concept, a holistic view of what's going on with the patients from both sides. So again, solving that misalignment, it's about transparency, data sharing from both sides. Payers can help the providers with their breadth of data. Providers can help the payers streamline their quality measures with their depth of data, and it's ultimately one source of truth. So what are some of the big focuses of quality moving forward? Big themes across the organization seem to be data interoperability, new data sources, simplification, and some common data standards and formats. And some of these things Melissa will be talking about in a minute. Real quickly, because I'm running out of time, some of the big organizations that are focused on quality, what's their response and focus in the coming years? For NCQA and HEDIS, they're really moving to a digital measures concept, which Melissa's going to talk about. They're looking at pulling in new data sources and supporting much more interoperability, such as electronic health records, health information exchanges and registries, case management systems, and of course, administrative data. For CMS on MIPS, they're looking in 2021 to create a new MIPS value pathway, which is really focused on a smaller set of measures that are really specialty specific and outcome based, and they really are more closely aligned to the alternative payment models such as value-based performance. It's really about aligning the measures and making them more relevant to the clinician's scope of practice rather than just having, tons and tons of measures. And then for star ratings, they're really looking at some more low-hanging fruit, things like generic utilization of drugs, prior auths, opioid prescribing, which of course is huge out there. But in terms of interoperability, they're also focusing on using encounter diagnoses from EHRs for HCC coding. So everybody seems to be really moving towards that concept of interoperability. And just real quick, some of the things to focus on that's low-hanging fruit, opioid utilization is huge. Telehealth is becoming more and more of a focus for quality measures and for metrics, and trying to understand how to market it appropriately to patients and members so that they adopt it. Advanced pharmacy analysis, we talked a little bit about generic utilization. It's specialty drugs, things like that, that can really make a huge difference in the bottom line. So in summary for me, setting yourself up for success in quality, you really need to understand your stakeholders' priorities and problems. You need to align your strategy across the health plan and healthcare systems. Keep it simple, keep it really focused. You need good data, good tools, and you need to understand that things are going to get easier, hopefully, in the future as quality organizations are responding to all of the challenges and trying to adapt moving forward. With that, I'm going to turn over to my partner, Melissa Linder. Thank you.
Thanks, Jason. Great information, a lot of information. So as Jason discussed, there are so many measures out there. It's a wonder that healthcare providers and payers have a hard time keeping it all straight. With all the various measures and ways to monitor quality and performance, why not add one more thing to the list? The world in general is becoming more technology focused. We have our smartphones, we have our wearable devices, and now we're throwing healthcare into that technology mix. We have the electronic medical records that Jason talked about, where providers spend most of their time. And we have this new concept of digital measures that are coming up on the horizon. What is the definition of a digital measure? According to NCQA, a digital measure is a digitized version of an existing HEDIS measure that payers and providers have been reporting to NCQA already over the last 30 plus years. These digital measures do use traditional reporting methods, but they're machine readable, and they allow for easier transmission and reporting, a lot more ease of that interoperability that Jason talked about. Some of the measures that we report are currently reported electronically, like the ECQMs through Medicare and the ECDS measures through NCQA. While these measurement systems are considered digital, the measures themselves do not really meet the true definition of a digital measure. These measures in the ECQMs and ECDS, they're things like smoking cessation, immunizations for adults and children, immunizations for prenatal patients, depression screening, fall screening, follow-up on depression and fall screening. So those are some of the things that we're already reporting through those measurement systems. And as Jason mentioned, there's a lack of patient-centric measure. And as the industry moves to the digital measure format, the hope is to really close this gap. We've discussed that providers spend most of their time in the EMR, so it only makes sense to be able to capture that data from the data for those quality measures from those systems that the providers and their staff are already using. It's going to reduce the burden on everybody who's reporting those quality measures. And also with the move to digital reporting, CMS has proposed, there's a rumor that CMS has proposed to focus more on outcomes measures that are more valuable to the providers and the healthcare population, gathering that measurement information through the EMR and digital transmissions. So what are the advantages of digital measures? Digital measure codes will be completed by NCQA. So the payers and vendors simply have to add the code to their IT system, removing the risk of human error through interpretation and recoding. We all know that we spend a lot of time interpreting the different specifications and how do we code that into our system. So NCQA is going to remove that burden. Those measures will be entered into the IT systems more efficiently and with the information that was intended by the authors of those measures. Health plans and providers are no longer interpreting the intent of the measure specifications and typing those interpretations into the systems. This is going to free up staff to focus on strategies to improve their overall quality of care. Digital measures also follow industry standards, which will allow HEDIS to be implemented easier across the continuum of care. This consistency and standardization means that healthcare providers can measure their quality using the same exact structure that their health plans that they report to are measuring. So it's going to be more of an apples to apples. Next slide. As part of this transition by NCQA to the digital HEDIS measures, we here at MEDI on the quality team have requested to join the digital measurement community. As part of this innovative group that NCQA is forming, MEDI hopes to learn with and from other stakeholders about the latest strategies and the best practices out there. Through knowledge sharing, challenges, and experiences, we hope to be able to discuss our challenges with implementing these digital measures and reporting, and be able to work with NCQA and others within the industry to create an efficient quality implementation and transition into this new wave of technology measuring and reporting. We are very excited about the opportunity to have early access to the digital measures, as well as have input in the development of those measures. Next slide. Now for a really quick lesson on quality management and improvement. As Jessica said in my intro, my background is quality in the healthcare realm on both the provider and the payer side. I am very passionate about quality and providing quality care to our patients and our populations. We all know that the basic principle of quality management is to measure, assess, and improve. In healthcare and in most industries, this is known as continuous quality improvement. In healthcare quality, we are in a constant state of monitoring our current performance and identifying ways to improve our processes to have those better outcomes. The focus may be on improving overall patient care, improving the health of a population, reducing costs, or improving the consumer's experience. But the process in each of these is always the same. We measure or collect the information for the purpose of understanding the current state, and we assess the information to determine if we are meeting those acceptable levels of performance, meeting our expectations. If we're not meeting those expectations, we're going to implement changes to the processes so that we can improve our outcomes and achieve better performance in our future state. But the big question that lies out there is, what are we measuring against to know if we're meeting those expectations? What are our expectations? Do we even know? Expectations can and usually do vary by organization. I know from experience, expectations from the provider world are completely different from the payer world, but we need to come together with those because in the end, it's in the interest of the patient. There is always a common theme in healthcare, and I think we would all agree that while we're working to achieve the triple aim as defined by the Institute of Healthcare Improvement, we're here to improve the quality of care, improve the population health, and to reduce the overall cost of healthcare. Next slide. So the Institute of Health Improvement does define measurement as a critical part of testing and implementing changes. I don't think that many of us in healthcare today would disagree with that. We're here to make things better for the population as well as for the providers and the payers. But how do we define what we're measuring and ensuring that we're meeting that triple aim? Payers and healthcare providers, just as Jason alluded, are subject to many regulatory mandates that drive the measurement of quality. Each regulatory agency has their own sets of measures and reporting requirements. Luckily, CMS, the state agencies, and most payers tend to agree that payers and providers must report clinical outcomes and utilization performances. While there is some variation in the measures captured and reported, it does seem that the NCQA HEDIS measures are the most effective measurement set to measure the quality of care, including the populations and the utilization of services. Did you know that nearly 2 million people are enrolled in health plans that report their measurements to NCQA? That's a pretty astounding number. The HEDIS measures are one of healthcare's most widely used performance improvement tools used for physicians, health plans, and other organizations to monitor their effectiveness of care, their utilization, including their risk utilization performance, and their plan performance. The CAP survey is the most commonly used patient experience survey tool out there. Once an organization has established what they are measuring and how they are measuring it, the next step is to determine if they are meeting their expectations. Before coming to Medi, I spent several years in the payer and the provider space in quality management and improvement. One of the biggest challenges that we faced, probably more so in the provider space, but really in both of them, was determining what were our expectations. We could measure performance and outcomes all day long, but it didn't mean a thing if we didn't have anything to compare those results to. We learned that there's many options out there when it comes to establishing our benchmarks and what we're going to compare ourselves to. An organization can develop their own internal benchmarks. They can buy external third-party benchmarks from various benchmarking vendors, or they can utilize industry standard benchmarks like the NCQA HEDIS Quality Compass. Next slide. So in the simplest terms, benchmarks are considered a management approach for identifying and implementing best practices at the best cost. In the provider space, we attempted to establish our own internal benchmarks using our first year as a baseline measure. So we started this in 2012 when the whole accountable care started to come to fruition. So we started in 2012, and we used our measurement year, or our measurement year, as our baseline. We quickly found this to be more challenging than we needed it to be. Our first year measurement was really based on about 12 providers and 36,000 patients. As time continued on, our provider and patient group base continued to grow, and over the next 4 years, we had more than 80 providers and 475,000 patients that we were monitoring performance and quality measures on. It was no longer valuable for us to compare those 475,000 patients to those 36,000 patients that we had started with in our baseline year. We obviously had a much bigger numerator, and the benchmarks became very irrelevant. We attempted to utilize other industry benchmarks and ended up using a hybrid version of both our internal benchmarks and our largest payer information, but it still wasn't giving us what we needed. It would have been really nice to have a standardized tool out there that we could compare our information to, our own internal information to, that was relevant to us, relevant to our geographical space, as well as the population that we were serving. Similarly, in the payer space, we had major issues identifying the benchmarks for our populations. We had initially utilized the benchmarks that were established by our parent organization in Detroit, Michigan, but we were in Des Moines, Iowa. And the population in the Midwest is much different than that population and the culture of urbanized Michigan. So that also became quite the challenge. As the director of quality in both arenas, like I said, it would have saved a lot of time and headache if we had benchmarks that were standardly developed using data from other organizations, demographics, and cultures that were very similar to our own. My team and I, as well as other teams within the organizations, spent a lot of time developing benchmarks and analyzing the data that turned out not to be valuable for us. And if you worked in a provider organization, you know that the providers always look at the value. What's the value to me? And if you can't tell them the value, it doesn't mean anything to them. They're just going to kind of push you aside. So it would have been really nice to have those standard benchmarks that would have allowed for easier identification of opportunities for improvement and determining where we needed to focus our resources for the best outcomes. Benchmarking should be a vital part of any healthcare organization's strategy, and without that benchmarking, how would organizations evaluate their current state to know where to place their resources to improve processes to have better outcomes for that future state? With that, I'm going to turn it over to Samantha Ferretti with NCQA to talk about NCQA's quality assurance programs. I will be back in a little bit to wrap up the quality benchmark discussion and how Medi-Analytics is implementing benchmarks for our clients. Samantha?
Great, thank you, Melissa, and good afternoon, everyone. So as Melissa mentioned, I'll just briefly touch on NCQA's background and how we impact the industry. NCQA was founded by Peggy O'Kane in 1990. So in fact, we're celebrating our 30-year anniversary, and we couldn't be more proud of our team for their commitments to measuring and improving the quality of healthcare. We started out as an organization aiming to measure the performance of health plans and grew into not only accrediting health plans, but recognizing physicians and practices for their performance across the nation. Essentially, Peggy's vision was that people need to know where to find good care. So NCQA evaluates health plan and medical practice quality. We create the standards, measure performance, and highlight organizations that do well. All of this helps drive improvement, save lives, keep people healthy, and save money. Next slide. Measure, assess, improve, and repeat. This is the heart of what we do. We establish the measures and standards that healthcare professionals use to identify areas that they can improve. The public reporting of performance against our measures and standards becomes the focus for groups we evaluate and their customers. By By releasing results to the public, it helps everyone set higher goals and continuing improving. Put this into perspective and echo some of the statistics Melissa had mentioned, currently more than half of the U.S. population is enrolled in a health plan that reports quality HEDIS results using our measures and standards. NCQA has the most widely used programs used to distinguish physician and practice quality, and currently we have just under 70,000 clinicians who have earned our seal of recognition. It's pretty impressive statistics. So given this, we are the industry standards and the prime source for our quality performance data. Given that, I will hand it back over to Melissa to wrap up.
Thank you, Samantha. So HEDIS measure certification is a rigorous process that vendors and health plans go through every year. This is a necessary step to ensure and validate that their measure logic is programmed according to the NCQA specifications. HEDIS software vendors are required to successfully complete the HEDIS measure certification in order to report those HEDIS measures on behalf of their clients. The certification also gives the organization that stamp of approval, indicating that their measures are coded accurately, can be reported correctly and accurately, and meet the specifications set forth by NCQA. MEDI just completed last week our 7th year of HEDIS measure certification, so we're pretty proud to wear that seal that NCQA gives us. Next slide. And to bring it all together, MEDI has recently partnered with NCQA to provide the information from their quality compass into our solution at MEDI. This allows our clients to easily compare the data, their current state, to the industry standard benchmarks without going to another website. All of the information is easily accessible in one place. Payers and providers can compare their current HEDIS rates as they are today to the quality compass benchmarks that are set by NCQA. Clients are able to see how they are, where they are falling within each of the percentiles, and they're also able to manage the their quality improvement data and monitor their performance in one location instead of having to go outside. This is going to streamline the improvement process to impact the quality of care, experience, and cost outcomes within their organization. And just as with Quality Compass, the benchmarks within the MEDI solution can utilize benchmarks for the commercial, Medicare, and Medicaid product lines. So as you can see here in the screenshot, we have the NCQA benchmark measure name. That's simply just the HEDIS name. We have the client's numerator and the denominator. This is dummy data, so don't be alarmed that we're only at a 0.06% compliant rate on our adolescent well-care visits. That's kind of scary for a quality director. But we can see as a client where that compliance rate meets with the average rate. And then we can also see where that falls within the 5th, 10th, 25th, all the way up to the 95th percentile. So it does give us that easeability, that transparency to be able to see how we're doing compared to the national standardized benchmarks. So as I indicated previously, as the Director of Quality in the payer and the provider spaces, having something like this in a solution and having the ability to compare our current state of performance to the national benchmarks that are meaningful would have made all the difference in our strategy development and planning for that future state. So with that, this concludes our webinar, and I'm going to turn it over to Jessica for wrap-up and Q&A.
Thank you, Melissa, Samantha, and Jason, for your time in presenting on this topic. As mentioned, there are a few minutes left for questions. If you've not done so already, please submit your questions via the chat feature to the right of your WebEx screen, and please direct your questions to all panelists on the drop-down menu. So we have a question. First question is for Melissa. Melissa, what are some strategies that can be used to get providers on board?
So that's a very interesting question, very good question. Coming from the provider space, it's very important to show the provider the value. What's in it for them? That's the question that you always have to answer before you even present something to a provider. I think it's very important to gain that provider buy-in. You know, in the organization that I worked with, we developed our quality improvement department. And in order to do that, we had to create pilot programs to show the providers what was going to be effective and what wasn't going to be effective, what worked, what didn't work. So it was quite a long process, but in the end, again, we just had to show them the value, what was in it for them. We had to have their buy-in. They had to feel like they had a say in what we decided on, and we had to be completely transparent with them through the entire process. So bottom line, get their buy-in.
And just chiming in, where I've seen some particularly innovative solutions where the health plan was driving the solution but really gaining the provider's buy-in, was having a shared solution that both sides could access. So basically the health plan was providing the provider organizations with a analytics solution, which they never could have been able to afford that type of solution. So they were super excited just about having the analytics, but also being able to monitor in almost real time how they were performing on their quality measures and being able to do some direct data entry of some of the chart abstracted type data into the solution really helped ease the burden of that end of the year HEDIS crazy rush time, and also really aligned the providers with the payers.
Yep.
Thank you. Another question, predictive algorithms generate a lot of buzz today. What do you see as important predictive elements around quality?
So I'll jump on that one. We have been working a lot with our end users around the types of things they want to see and things that they're excited about in terms of predictive. Predictive really is a buzzword, and everybody's throwing it out there, and not everybody has a real directed focus of what they want to do with predictive. But one of the things that we're looking at is the patient impactability score. So by looking at what's gone on with the patient historically, understanding, their gaps in care and a lot of different social factors that might be contributing to how they're responding to closing those gaps in care and how responsive they are. This score helps basically to understand the patient or member's willingness to change. And so it can help tailor where you're spending those resources that you have that are so precious in outreach programs. So you can understand where your members or patients might very easily change, and so it might just take a gentle reminder, as opposed to those patients or members who might take a little bit more effort in outreach.
Thank you so much. This concludes today's webinar. Have a wonderful day.